Good morning. First, I would like to thank Mike Picos for the great opportunity that he offered me to be part of this wonderful program. And of course, I would like to thank the ICOI committee for this great opportunity. Mike had tasked me with the implant management in the aesthetic zone. And we have seen this morning quite a bit of amazing work and, of course, literature and science related to this topic. What my hope and my goal is to bring you some of the science that we have worked on, but also the clinical practice day-to-day that affects you and I as we treat our patients on a daily basis. We start to wonder, how do we take a patient from here and to bring them to this point to achieve that ultimate aesthetic results? Well, it is a combination of multiple factors. It is the implant itself, it is the surface treatment, it is the macro design of the implant, the micro design, this hard and soft tissue response that this implant will elicit as it is placed and it heals in the mouth, and of course, a very careful planning as you start. When we take a look at somebody and we look at their smile line, and sometimes we may not see a lot in such a situation that looks like this. But to bring that patient to that part with that type of smile line may not be very difficult. And there are things that we can do to overcome some of these situations. But if we look where this patient started and what needed to be done in order to achieve that result, that case is clearly very challenging. But we will fail if we don't know what we want to do and what we want to achieve from the start, knowing that this patient does have a very low smile line or moderate. There are certain considerations for the aesthetic site. Well, we need adequate bone. We need a precise placement position for the implant. We need a stable abutment interface connection. And of course, there is a great talk about platform switching and implant design. So we will talk about that. The micro gap is a very integral part of that problem. We need an ideal emergence profile, and we need the same appearance as the adjacent teeth. So clearly, this is very challenging and very demanding to get there. And of course, the literature is very abundant on aesthetic implant dentistry. So you and I, as we open the journals and the literature, or we go online, there is tremendous, overwhelming evidence there that focuses on this topic. But what I hope and what I would like to do is to break it down to hopefully to a level that you and I can actually achieve and do in our private practices. So as we look at this patient, and we were faced with this very large deficiency of what seems to be soft tissue, but of course it is there because there is a deficient hard tissue in that process. As we can see, those two teeth are convergent following a car accident, and in order to bring them back into a certain position and do some forced eruption, we diverge them first, and then we start the process of forced eruption. We know clearly from the beginning that this is not what is going to make this case. We know that this site is very deficient and would require regeneration. And finally, going from here to here, we achieve that. But is this enough? Is this what we need? In order for us to determine if this is the adequate volume, first we have to take a look at where we started. And at first look, it looks like we did not so bad. But if you take the free gingival margin of the adjacent teeth, and also that looks like we've probably improved the situation, but also that's not enough. What we really should be looking at is, did we achieve this? Because it is this tissue here that will dictate whether we achieved the ideal results or not. And if we did not, therefore, this could become a catastrophic failure, especially if we have very high smile line. Finally, in this particular case, fortunately enough that we were able to get away with this and restore this patient to such results. So in order for us to focus on the management of the implant in the aesthetic zone, we have to look at the anatomical requirement for implant placement. We are also going to look at the modification of hard and soft tissue response, and then I will share with you some conclusions. So let's take a look at the anatomic requirement for placing an implant. So we must always start with a diagnostic wax-up for the ideal tooth dimension. Incisor-gingival, buccal-lingual, mesodistal, in all directions, as you can see it here. And we need to understand that relationship that it has to the alveolar ridge and how deficient it is or how adequate. What we want to avoid is implants that come across exiting in this position, because it is not only that it is a compromising position, it is a position that will further cause recession in this part of the mouth. And of course, we want to eliminate some of the gymnastics that we do in prosthetic dentistry, so to make it simpler. One of the things that we focus on, if this site is deficient, and I will discuss that in details, that we must correct all aspects of the deficiency, that is buccal, crestal, and palatal. And yes, it is predictable. There are multiple techniques, and I know Dr. Picos will be talking after me on this topic very extensively. We can predictably take somebody from here to achieve this result. And yes, we are overcorrecting, because if we want to achieve what we want, or we need the results, the volume that is required, we must overcorrect our site. So therefore, also our selection of graft material becomes very, very critical. The treatment of ridge deformity has been around for a very long time, and we've tried multiple techniques, from GBR to block graft, distraction, osteogenesis. And yes, in some cases, if it does not involve the aesthetic zone, maybe short implants. And of course, you and I were hearing a lot about the evidence with bone morphogenic proteins, and maybe we go in that direction and achieve also great results that way. But also I want you to focus at this. Pink ceramics also is one of the treatment of ridge deformities, and there are cases where we might resort to this because it is the only option or the most predictable option. So let's take a look at our site assessment and preparatory procedure for a single tooth implant and for the multiple sites. For the single tooth implant, it is very important that we understand the biotype that we are dealing with, the root length and width and angulation, position of the adjacent roots so we can place an implant in that site, proximity to anatomical structure, and we also need to keep in mind as we enter this, the macro and micro implant design, abutment design and material. And one factor that we rarely hear of is the perioral muscle action, and what influence does it have, excuse me, on what we are doing. So one of the protocols that we have been following for many years, and I was listening this morning to the different speakers, and the focus seems to be always that extraction socket and what do we do with it? Does it really work? Are we doing the right things, or we are waiting for a surprise to happen to all of us at one point? So let's take this patient that has tooth number 13 that was fractured, and also the same patient I will share with you, tooth number 4. Both of them were fractured the same day. Our protocol is to do an atraumatic extraction and immediately right after that determine the level of the mid-buccal crest of bone, because that's what will dictate what we will have to do. And then place our implant. And our protocol is the following, that implant should always be 1 millimeter below the mid-buccal bone, because that's what will dictate that position. Also, one of the protocols that we have, and we have been doing this for some time now, is to place one abutment. And as you can see, we're saying here, one abutment one time. So this is the final abutment that you are going to place for that patient. You are going to place it, temporize that same day. So we believe that immediate implant placement also comes with temporization, should be out of occlusion. Leave that abutment and eventually use it as your final restoration. And of course, this work has been done by Berglindi some time ago in the late 90s. But we must examine, are we successful with this? What is happening? Are we achieving the proper results? So if we look where the free gingival margin on tooth number 12 was, and we follow, it stayed intact, and that's where we are now. This is where we started, day one. Yes, we lost maybe 0.5 millimeters, but in this particular situation, it did work, and it worked for few reasons, and we are going to discuss that as we go. And papilla height changed a little bit also in this particular part. But this is not the aesthetic zone. But we need to understand the dynamic of that site and see if we can extrapolate what we are doing there into the aesthetic zone. And if you look at the bone level, this implant was placed in August 2005, and you can see up until 2009, that dimension was very stable. And it is stable through the macro and micro design of that particular implant, the stability of the connection, and possibly, I cannot tell you for sure, that the fact we have used one abutment one time only. We did the same thing on the other side. The same day the implant was placed on the other side, and we followed the same protocol. And what I'm trying to show you here, that the ridge contour also, which is very important, has been maintained. Now, knowing that we know this, and we have been doing it for some time, maybe that gives us an opportunity to say, maybe this could work, and maybe this is the direction that we should be going into the aesthetic zone. But also to do this, you have to follow certain things. We are not looking at osseointegration day one, but we are looking at very high initial stability of that implant. The osseointegration will be tested at a later time to see that we have achieved it. But what we do as a protocol, we use the Ostel unit as we place these implants to make sure that we have high initial stability. And if we have anything that is less than 65, we are not loading these implants the same day. We will actually load them at a later time. So it is very important that you have this as part of your armamentarium to determine that you are doing the right things. And what we are measuring here is the stiffness of that implant relative to the entire environment that it is in. And this is not really insertion torque. It is different. So we want to make sure that this implant and its environment is all stable, and you achieve that result. Peter Moy and his team presented a poster presentation at the AO in 2009 and presented a guideline of how you use this particular technology and how do you achieve it. Now we are so confident that this is a direction that we need to look at very carefully. I have been placing these type of implant and restoring them immediately with provisional in my practice for probably a period of 10 years. And now I have the opportunity to actually look retrospectively at this data and examine how well we did. But also as we go forward, we're looking at different implants prospectively and to see what are the opportunities that we have. And one particular area of focus that we have, again, is that stability of the mid-buccal soft tissue. And whether one implant is different than the other, that still remains to be seen. The multiple site, however, they're slightly different. And yes, if I showed you always two central incisor, I think predictably many of us here in the audience will achieve this type of result. But this is not the real problem. The two central incisors, we can achieve this result placing two implants if we have adequate hard and soft tissue. But the problem is a lot more challenging when we start to deal with symmetry and when we are dealing with a lateral incisor and a central incisor. So if we look at a deficient ridge, we clearly have to look at it in its all dimensions. That is the buccal, crestal, and palatal to achieve what we want. There are multiple ways and multiple techniques that that this can be done. And this is only one of them. It is a particulate graft, a xenograft. We're trying to achieve guided bone regeneration through the use of barrier membranes and graft stability and containment. And ultimately, we are looking for that dimension that is about 10 millimeters, because if we are going to place an implant that is about 4 millimeters, and this graft dimensionally changes about 15 to 20%, then we need to compensate for that as we create it. And at re-entry, we see that we have achieved the objectives that we have achieved the width, but also it is very important to achieve the height. If you don't reach this area here and you still have a concavity here, your soft tissue will be compromised and you may not be able to do what you really intended to start with. On a post-op CT scan, we see clearly that the ridge was augmented in all dimensions, buccally, crestally, and palatally, to do what we want. And finally, once we know that our hard and soft tissue is stable, as we have seen earlier this morning, we go ahead, we place our implant. But nevertheless, these two implants here, they're adjacent to each other, as you can see. And yes, based on some of the research that we have done at NYU, we know today that these two implants can be as close as 2 millimeters to each other without the influence of the implant and the interface on the surrounding bone. But does this mean that you are going to have more soft tissue? I assure you, I have not seen it yet. So let's not mistake this. We can preserve the bone. We can do all the things that I'm telling you we can do. But to expect a greater volume of soft tissue around these implants, I have not seen it. But it's all in your treatment planning and how you see your practice and how do you practice. So we have to define some strategies in our treatment planning. And conventionally, we thought we'd just take a tooth out, let the site heal, and eventually we can regenerate. So we've done this for many years. Today, we think we're going the other way. Let's preserve everything. We don't possibly need to regenerate if we do the right things in terms of preservation, that is immediate implant placement or socket preservation. But of course, there is in between both of these things, the reality. And my fear as we enter these areas, that we continue to swing to some extremes. Today, I don't believe that every site is an immediate implant placement, but also I don't believe that every site should be regenerated. Because in the middle, there is the restorative dentist, the prosthodontist, and the patient, that they're suffering from some of the things that we believe that are doing what is expected. So in our treatment planning today, we have a protocol that I define as the following. First, we need to look at the incisal edge of the teeth that are going to be replaced in the aesthetic zone. And that is very important because it will dictate phonetics and it will dictate pretty much the entire aesthetic outcome that you are looking for. Following that, we are going to look at the level of the interproximal soft tissue on all the teeth in that site. And third, the height of the free gingival margin on all of the teeth, because all of these must work hand in hand in order for us to achieve our ideal results. But that is not enough. That scenario has to fit with the mouth, with the lips, and most importantly is the smile line. If the smile line is very high, then we have to really think very carefully if our regenerative procedure will achieve this outcome and we can bring the soft tissue to this particular height. So as I do my treatment planning differently today, I call it the 3 R's of treatment planning, and we follow this protocol every single day in our practice. It is replace, reduce, and redefine. What we are hoping for is to replace some of the concepts and beliefs that we have, because technologies and science are advancing, so therefore we cannot continue to do what we have done 10 years ago. We want to reduce morbidity and the treatment time. You know, it is very difficult for me to look at a patient and tell them, I'm going to finish your treatment in 1.5 years because I need to do bone augmentation, I need to place implants, and I need to do all these things that you need in order to be treated properly. But also, I think it is time to redefine our knowledge and redefine new standards, because the standards that we have worked with in the past, they're no longer the standards that I think are happening today. So in terms of regeneration, as I mentioned earlier, our requirement is first you select the site that you are going to restore. We must understand the tooth dimension perfectly, so therefore a diagnostic wax-up and imaging, as we saw from Dr. Gans and Rosenfeld yesterday, is very, very critical, because that's what will dictate and allow you to understand that the site has to be grafted in all of these dimensions. And always keep in mind that you have to overcorrect it. But let's go to our preservation. There are 2 possibilities there that we have. If you don't have the training, or you don't have what you think your comfort level allows you to take a tooth out and place an implant, then you should do what we call an extraction socket preservation. And in order for you to do that, you take the tooth out and you fill the socket with a graft material of choice based on the literature that you have looked and researched. And then, at a later time, you could always go back and place your implant. This work was done by one of the residents from NYU, Emanuele Closa. He's here in the audience, to show the changes that actually are taking place as we take the tooth out and if we do nothing about it. And we've heard this morning from different speakers that yes, these changes are real and they're very significant. Therefore, they can compromise everything that we are planning to do. So if we take this tooth out and we do nothing in this socket here, the changes could even come up to close to 3 millimeters in some cases. And that is huge. In order for us to go and regain that would be a very, very difficult task.